morning, friends. Today's topic of discussion is on salivary gland tumors. This is a commonly asked question in the examination, and if there is a case available in the wards, it will definitely be given in the examination. But what is important is that it makes up around 6% of all head and neck tumors. But if you look at the incidence, these are the US figures, it's about 5 cases per 1 lakh individuals. I was looking up on the Indian figures, that's about 2.5 per lakh of patients. In other words, an average general surgeon is not likely to encounter too many of these cases in his lifetime of practice. And even amongst all the tumors, the number of malignant neoplasms account for only 0.9%. So per lakh. Mortality from malignant salivary gland neoplasms, it varies by stage and pathology. Obviously, it applies to most, this statement applies to most of the malignancies, and so it is with salivary glands. And the overall survival rate is about 72%. In fact, I will show you the stage-wise survival rate in my last slide. Now, what are the broad facts? Like if you see the figures, global figures, that 1991 to 2006, about 684 cases of salivary gland tumors were analyzed retrospectively. Look at the period, 9 years, 15 years period, right? Of which 62% were benign and 38% were malignant. In other words, larger number of tumors are benign and malignant are less, and of which 61% were in the parotid gland. So most of the tumors do occur in the parotid gland, and I think this is the common impression which all of us have as well. And 17% only occur in the submandibular gland, and 22% occur in minor salivary glands. You must be remembering that minor salivary glands run up to a number of around 1,000. And they are all over the aerodigestive tract. That means inside the lips, inside the cheeks, and in the pharynx and larynx and paranasal sinuses, they are all over. But the number of tumors they cause is about 22% in the minor salivary glands. And the most common benign tumor, thankfully, is pleomorphic adenoma, 86%. And the most common malignant tumor is adenoid cystic carcinoma and mucoepidermoid carcinoma. They actually follow closely, although statistically it looks like adenoid cystic carcinoma is 25% and mucoepidermoid carcinoma is 18%. Among the minor salivary gland tumors, most was seen in the palate. I'll show you the pictures of these in the clinical presentation. So what do we learn from this slide? Thankfully, most of the tumors are benign. Most of them occur in the parotid gland, and most of them are pleomorphic adenomas. So that's what we learn from this particular slide. It is natural to look for etiology of such a rare kind of neoplasm. And when you look at the etiology, it is good to remember these diagram before I talk about the various types of etiology which have been postulated. And here is the acini. Basically, when you look at so it is natural to look for the etiology of such an unusual neoplasm, and there are certain theories about the origin of such a neoplasm. But before we go into the theory, please look at this diagram. And this diagram is showing actually an acinus with the duct system. Now these are the cells of the acinus, which is the epithelium, right? And just outside that will be the myoepithelial cells. And onwards, further onwards, there is an intercalated duct, a striated segment, and excretory duct. Basically what happens is that when you look at this, as supposing this is the acinus, several of these ducts will join together, and then further on join together to form the main excretory duct. So in these segments you have intercalated duct, striated segment, excretory duct. And it is postulated that the malignancies arise from these cells. How they take place, how they arise, there are two theories. Now I have written something here. For example, excretory duct, I have written mucoepidermoid carcinoma. Intercalated duct, I have written adenoid cystic carcinoma. So there are two theories. One theory is called bicellular theory. Other theory is called multicellular theory. Let's look at it. The first one is the bicellular stem cell theory, and according to this theory, it is believed that there are two undifferentiated cells, or the stem cells, from which the various tumors will arise, both benign and malignant. And so each of the tumors will arise from one of these two undifferentiated stem cells, the excretory duct reserve cell or the intercalated duct reserve cell. I have shown you the picture. And so one of these two cells, the tumors arise. Excretory stem cells give rise to squamous cell and mucoepidermoid carcinoma, which also I showed to you. And intercalated stem cells give rise to pleomorphic adenomas, oncocytomas, adenoid cystic carcinomas, adenocarcinomas, and acinic cell carcinomas. This is one theory. This is called bicellular stem cell theory. Essentially what it comes down to is there are two undifferentiated cells and different tumors come out from these undifferentiated cells. One of these cells is lying in the excretory duct, and other of these cells lying in the intercalated duct reserve cell. Now there is another theory which is called the multicellular theory, and this theory believes that for each tumor there is a separate cell of origin. Let us put it in a simple format. There is a separate cell of origin. For example, squamous cell carcinomas arise from the excretory duct cells. Pleomorphic adenomas arise from the intercalated duct cells. Oncocytomas arise from the striated duct cells, and acinic cell carcinomas arise from the acinar cells. So this is a simpler format as compared to the bicellular theory, but recent evidence suggests that the bicellular stem cell theory is the more probable etiology of salivary gland neoplasms. Now there are also some associated factors, and one of the most important one is this radiotherapy. Now if you had an exposure to radiotherapy for any reason, then parotid neoplasms can take place 15 to 20 years after that particular treatment. And so the incidence of pleomorphic adenomas, mucoepidermoid carcinomas, squamous cell carcinomas, all this is increased. So this is one definite factor which you can say is factor 1. Second factor, regarding tobacco and alcohol, normally these are very closely found to be associated in head and neck cancers. But this kind of association is not very clear in salivary gland neoplasms. Like tobacco smoking has been associated with the development of Warthin's tumor, that is papillary cystadenoma lymphomatosum. I'll show you the histology of this particular tumor and you will understand why it is being named like this, papillary cystadenoma lymphomatosum. Right, so it has tobacco smoking probably associated with this, but other than this, there is no clear-cut association between tobacco and alcohol with salivary gland tumors. Some studies do indicate between occupational exposure to silica dust and nitrosamines. So this is another possible etiological factor. So these are some of the three of these factors, and associated with are found associated with the origin of salivary gland tumors. Is there a pathophysiology? Now it is not rather uncommon, to be able to look at pathophysiology of all tumors, but there are some suggestions here in the salivary gland tumors. Exact molecular mechanism by which tumorigenesis takes place is of course incompletely understood, but there are certain pathways and oncogenes have been implicated, and some of these oncogenes have been implicated in various malignancies, and therefore the names will appear familiar to you. One is P53, BCL2, MDM2 and RAS gene. For example, you must have heard of these genes being blamed for various malignancies. HRAS mutations have been shown in a significant proportion of pleomorphic adenoma. This is something that we can remember and probably important to remember. pleomorphic adenoma, adenocarcinoma, and mucoepidermoid carcinoma. So statistically, pleomorphic adenoma being the commonest. Similarly, mucoepidermoid carcinoma is also is a common salivary gland malignancy. Up to I showed you the statistics up to about 12%, right? Adenocarcinoma is not so common. So in this, the HRAS gene has been implicated. And there is another one, the vascular endothelial growth factor. The vascularity is expressed by over half of salivary gland carcinomas. Later on, we will talk about it. We utilize this phenomena in contrast administered ultrasounds to find out the difference between Wadden's tumor and other salivary gland neoplasms. So whatever, coming back to this one, the VEGF is expressed by over half of salivary gland carcinomas tested and is correlated, this is important, with clinical stage, recurrence, metastasis and survival. This is a very important thing to remember. So these are playing a part in the pathophysiology of the tumors. There are various other sort of factors too, genetic factors and chromosomal factors. Like now 70% of pleomorphic adenomas have associated chromosomal rearrangements, the chromosome concerned being this. And in mucoepidermoid carcinoma, there is chromosomal transallocation. That means this one is a rearrangement, this one is a translocation, right, in mucoepidermoid carcinoma. And there is involvement of tyrosine kinase receptor CD117 or c-KIT that is found in adenoid cystic carcinomas. This distinguishes adenoid cystic carcinoma from low-grade adenocarcinoma. This can become very important as we will see later. And chromosomal loss has also been found to be an important cause of mutations and tumorigenesis in salivary gland tumors. So we got various things going on, say rearrangements, translocations, chromosomal loss itself, and of course the role of tyrosine kinase receptor, c-KIT.